Good afternoon, everyone. Thanks for joining us for this WebEx on the Hertfordshire's Vanguard Complex Care Premium. I'm sure there'll be people joining us throughout the session, and we're just going to go through the slides today. Okay, so we've got two main presenters. Myself, Paul Benton, I'm the Programme Manager for the Vanguard in East North Hart, and
Michelle Airy, I'm the Integration Manager for Hertfordshire Care Providers Association.
Okay, the WebEx has 3 parts, and between each of the parts we're going to have some interactive polls and also videos. During those times you'll be provided with web links to YouTube in the chat room, so please make sure that you've got your chat window on the right hand side open. Any questions, please post throughout the WebEx, and then a colleague of mine, Sue Wales, will be collating all the questions and we'll go through them between each part. And finally, this WebEx is being recorded and it will be uploaded onto YouTube. The slides will be uploaded onto SlideShare, and an evaluation survey will be sent out afterwards, which we'll appreciate everyone completing. Okay, so I mentioned the WebEx is in 3 parts. The first part is talking about Hertfordshire. Okay, so we know from the NHS 5-year forward view that 1 in 6 people aged 85 or over are living permanently in a care home, yet data suggests that if they had a more active health and rehabilitation support been available, some people discharged from hospitals to care homes could have avoided permanent admission. So, we have 50 Vanguards last year, and there's 6 just focusing on care homes. So last year, East and North Herts CCG, Hertfordshire County Council and Herts Care Providers Association, HCPA, put a bid together in August last year, and we became a care home Vanguard site. So we work with our partners in the East North Hart, so that's ranging from the Acute Trust to the Community Service to Hearts Urgent Care, who monitor and manage the 111 service, and the East of England Ambulance Service. So our Vanguard programme has 4 components, which is Confident Staff, which focuses on upskilling staff to feel more confident about supporting residents, health and wellbeing, multidisciplinary teams that support from and advice from pharmacists, dietitians, etc. Rapid response teams, wraparound services, and that's not just, we're not talking about ambulances there, we're talking about individual rapid response teams and effective technology and looking at data. So we have a range of 14 projects, but this presentation is just going to be speaking about the Complex Care Premium. Just to give a bit of history in Hertfordshire, integration has been key to rolling out the Vanguard. In 2014, we had integration with health and social with wheelchairs. Then over time it progressed to mental health. Detox fines were pulled, the Better Care Fund, and Vanguard, and looking into the future, the SPP. So I'm just going to hand over to Michelle here, who will talk about the HCPX.
So Hertfordshire is quite unique in the way we engage with providers, largely down to the integration work between Herts County Council, the CCG and Hertfordshire Care Providers Association. So we wanted to take a few minutes to talk a bit about how Hertfordshire Care Providers Association works with linking with providers across Hertfordshire. Unfortunately, with these WebExes, you can't play a video in the WebEx. So what I'll be doing instead is pasting a link into the chat that then you'll be able to click on and watch a video. If the video link doesn't work the first time, click on it again and it should work. We have checked them today. So what we want to do now is we'll take until 12:15 if everyone could watch the link. It's now in the chat Any issues, please comment in the chat box.
It's Sue Wales here, and may I just add for people who are not used to the WebEx that the chat boxes are on the right-hand side of your WebEx screen, and you'll see a blue bar that says chat. If you open that up, that's where you can see the link that Michelle has just put in for you.
Hello again, everyone. I know a couple of people had issues with the link. Sometimes the link is working fine here, so sometimes it can be different browsers. So what we will send around the link afterwards as well if anyone wants to have a watch afterwards. Really, it just gives you an overview of what we do as a company, that we work with all adult social care providers across Hertfordshire, whether that is a residential and nursing homes, but we also work with day services and home care providers. Our main ethos is to raise quality of care working in partnership with the local authority and the CCGs. We really are here to represent the providers, which is why we get a lot of buy-in from providers in Hertfordshire, because they want to work with us and we give them that support to be able to do lots of additional training and get involved in projects that we run. So to make this possible, we link with a number of organisations. So the biggest one being Hertfordshire County Council, who we've been working with now for 6 years. Then in the last 4 years, we've been doing a lot of work with both clinical commissioning groups that are across Hertfordshire, We work with Skills for Care on the workforce development funding and other projects. We work with Hertfordshire Adult Learning Service for a number of projects that we do in the home, public health, and any partners that we can work with that are going to benefit adult social care in Hertfordshire, we will partner up with them and come up with different ways of working. So the different ways that we engage with our providers is we have a membership structure where people can engage in different ways. We send out regular e-newses where they can just find out up-to-date information that's happening in the sector or Hertfordshire specifically. So if there was a safeguarding policy update, we would make sure that went out in our e-news. Someone could just be a member like that. With paid membership, they can access a number of training courses and services, which is where we move on to our focus on workforce development. We largely started out working on management training, but we have moved on to do more specialised training as well. With our management training, we focused on like new managers, so team leaders who needed to develop management skills, or all the way up to the home manager maybe doing some work on the behaviours in the organisation and retention and recruitment issues. So we look at a wide variety of training packages. We will send a link out to our website at the end where you can see all the training that we do. I won't go into it in detail because we're going to look at the complex care premium training in detail. We also then have other membership structures where people can become silver and gold members. We have this structure, it's not about how much they pay, it's about how much they engage as an organisation. So to become a silver member with us, an organisation has to engage in management training, so it shows that they are trying to improve their management structure within their organisation. And then our final part is our gold membership, where people have to undertake our impartial feedback service. The impartial feedback service we will touch upon later, but as an overview, it links in with the key lines of inquiry with the CQC monitoring. And what it really is it's independent surveys that go out to residents, staff members, professionals working with organisations, and families and friends, so we can get an impartial view of what is happening in that organisation, because we collate all the information, nothing goes back to the home directly, and we're then able to produce a report and see where the home is meeting certain criteria. And then from that, it can bring out an action plan of areas that they need to work on. And that's why that would give them gold membership status, because it shows that they're looking at where they need to improve and they're taking direct action to change that. One of the other areas, we hold regular network events with any provider can attend by being a member, where we'll look at a certain subject area that's important for the time. So back in March, we did an event all around recruitment and retention issues, which obviously is one of the biggest issues across the sector. And then we try and find any way really to offer information, advice and support to homes, whether that's through events, through trainings, just having up-to-date information on our website, and also our e-news that goes out regularly. Our funding from the training comes from various places. We run some courses, the odd ones, that our members pay for to attend. In terms of the majority of our workforce development training comes from the Hertfordshire County Council Learning and Development Department. We additionally manage funding from Skills for Care for the qualifications, and then we also manage the mandatory funding pot from Hertfordshire County Council, where a member can run training in their own homes, mandatory training, so safeguarding or moving and handling. If they use a training provider that we've approved, they can then claim back money for that training in their home. In terms of membership fees, we charge a standard fee for the year of £60, and that's it for the whole year, and then they can access everything. And then if there's the odd course, we sometimes run the award in education and training, which is the qualification on how to train, which isn't something we get funding for, so that's an example of something that we would do at a fee for the member. So that's just kind of an overview of what we do. And this isn't just where our company is unique to Hertfordshire, but a lot of these activities aren't necessarily unique around the country, because there's lots of workforce development departments within the local authorities who are doing similar workforce development training, similar ways of people to claim back funding. Obviously, Skills for Care workforce development happens across the country, and different people manage that in different areas. So I wanted to just point out that we're not saying that you have to have a providers association to be able to do these things. This is just how we do it in Hertfordshire. So we wanted to, now that we've touched upon really integration and how we work in Hertfordshire, we wanted to do a short poll, which I will let Paul introduce.
Hello everyone. Okay, so if we look on the right-hand side, where you've got your chat window, if you look top right, you'll have a little tab that has polling. So what we wanted to do is add some interactivity to this WebEx. So if you click on the tab that says polling, and we're going to be going through a couple of questions here, and I'm going to allow 2 minutes for people to submit their responses. And I'm just going to open the poll now. Just going to give people 2 minutes for this, and all of the polls will be shared after it. Okay, we're getting some responses so far.
The tab for the poll should be on the right-hand side next to the chat.
Okay, we've just got the final 20 seconds, and then I'll close the poll. Okay, thank you for everyone for submitting their polls. I'm just going to show the poll results. Bear with us. So if you look on the bar on the right-hand side, you'll see people's responses. So for the first question about care home commissioning, about does your local authority and CCG share finances? We've got 11% saying yes, 41% saying no, and 48% is don't know. And then moving on to the next question, which is how integrated is your care home monitoring arrangements between the local authority and the clinical commissioning group? We have 15% which is fully integrated, 48% which is partially integrated, 4% which is not at all, and 33% unsure. And then for the final question, number 3, Does your clinical commissioning group and local authority commission care homes jointly? We've got 11% yes, 41% no, and 48% don't know. So thank you for that. We will send the results when we send the slide out as well. And we'll move on to the next slide. Thank you.
Lovely. So now I'm going to talk a little bit actually about the development of there's a little bit of history before we started the CC Premium, but we'll talk a bit about how we developed the training before then. Because as a company, as HCPA, we've been running what we call an advanced champion pathway for around 4 years now. And really what we see an advanced champion pathway as is where you have someone in your home in a particular subject area who can champion that any issues with it. So say we run the dementia pathway, so we really see the dementia champion as being able to work with residents with certain behaviours that may be challenged. What do they need? How can they work better with professionals and really be the go-to person of knowledge, which is why we train them to be able to teach back in the home, we train them to be able to coach, and we train them to be able to mentor. So really what you end up is someone with specific knowledge for the subject area. They're able to teach, coach and mentor, and we also give them some form of level of a unit qualification around the level 3 mark. And we do this because we are calling it an advanced pathway. We want to show that this is a higher qualification. So they would be doing, if it was the dementia pathway, for example, they would do the Dementia Awareness Level 3 QCF unit. And so they would get that, they would get their teaching qualification, they would do a coaching qualification, they would learn how to mentor, and they would do their subject-specific areas. Now, later on, we are going to look at subject specifics for the pathways that we cover within the Complex Care Premium. But to give you an example at this point, if it was the dementia pathway, their subject-specific areas would be dementia environments, intimacy in dementia, mental capacity. They would do positive interventions. They would do good use of antipsychotic meds. They look at all the very specific knowledge that they need around that area. So in the end, so that would be what your champion would training, and then the idea that they can go back and cascade their knowledge. We then additionally have a manager running alongside it. We want to include the manager as part of this training, because if you don't get the manager's buy-in, the champion often can't make changes back at the home, and they won't help with the improvement plans. So what we do with the manager is do some training around strategy. So we will work so they really understand what their champion has learned and what they can do to put that in to their home. Or we also run these courses in home care as well. And then on some of our training, we do a level 5 unit, QCF unit for the managers as well. We are in more recent times with the complex care premiums and our other pathways moving away from that unit and only doing it if the managers request. This is largely because we're very understanding that the managers have got a lot on and a lot of work to do, and actually asking them to also do that unit was too much, and actually we wanted them to be able to focus on the strategy side of implementation of what the champion has learned into the organisation. With our pathways, we would do assessments at the beginning and end, and we try and bring the champions and managers back in a few months afterwards so we can find out what changes have been implemented, but also to review our training, see if there's anything we need to update or any issues with training providers, to just make sure that we're always on top of and improving. Now, on the next slide, I'm going to talk a bit more about what we expect from a champion. So once that champion has done the training, they've got all their knowledge, all that knowledge needs to be cascaded back into the home. So we want them to be able to train back in the home. So we train them, it used to be called PESOLs in the past, but now it's the Level 3 award in education and training, which is a qualification on how to train. So we teach them in that, and we do a toolkit with them so that they can pass their knowledge back onto staff in the home in a formal way. Additionally to that, we want them to be mentors to the home so that they can work with staff one-to-one straight away as things are happening. So that's a bit more on the floor kind of work. And then the last bit that we expect them to do is coaching. So to be taking a bit more of a role in getting staff to find the answers themselves rather than giving the answer to them. So really you end up with someone who's able to train formally, mentor one-to-one, and then develop staff so that we can make sure knowledge is being passed on to all different learning styles. So that's a very brief overview of what we do as a champion pathway, and we've been running that for, so as I said, Dementia Pathway has been running for about 4 years in Hertfordshire. This is before any of the Vanguard projects. So we've been running that pathway. We do it with residential and nursing homes plus home care. Then we started doing a nutrition pathway after that, and we also do a safeguarding pathway. And these came about with consultations with the local authority learning and development department, that they were the areas that were needed to have champions within the homes. I mean, some homes also have other people that they call champions, but we segregate ours as the advanced champions that specifically do these expectations. So before we actually move on to start talking about the premium in a whole, I'll just hand over to Paul for a moment.
Okay, so as previously mentioned, the 14 projects we've got for Vanguard focus on the 4 areas we've mentioned at the top. I just wanted to take a couple of minutes to talk about them. In enhanced GP care, what we've done in East North Herts is align a GP surgery, or for the bigger care homes, a couple of GP surgeries with one care home. We have a care home trusted assessor who acts as the intermediary between the hospital discharge team and the care homes, the skilled care home staff, which is what we're talking about at the moment. We have a community-linked geriatric team, supportive technology. We're looking about getting System 1 access into the care homes, and we're looking about how we tackle that, looking at IG and training. The wraparound services, so as previously mentioned, this isn't an ambulance, but this is a rapid response team that the care homes can call and actually help them in a non-emergency situation. Penultimately, we have a care home pharmacist who goes into the care homes. What they do, they go through the Mars folder, they make recommendations, and they link back to the aligned GP. And finally, we have some end-of-life nurses who go into the care homes, and they're starting to provide some training for the care homes.
Okay. So now is the bit when I'm going to start actually talking through the project that we've done, the Complex Care Premium. And I'm going to start by talking about the problem, then I'm going to talk a bit about the mandate, how we created the project team, how we analysed what we needed to do, how we developed, which will be a really big section, how we engaged with the homes and delivered the project, how we supported the homes afterwards, and how we evaluated. So they're just the stages that we're going to talk to, and I'll review those back at the end to show you where we've covered them. So the first part was the problem. So as we've already discussed, and this is a national problem, not just Hertfordshire, but there's increasing staff pressure across the NHS and across the private social care providers. There's high amounts of unplanned admissions, lots of transfer delays coming out of the acute, and lots of poor outcomes. A lot of it is down to increased complexities of patients that are, for example, more at risk of falling or more at risk of developing certain wounds, who then end up having to use services. So that's the problem in Hertfordshire. And what then we had as a mandate is that we need to, what can we deliver in Hertfordshire to reduce the use of services, bridge the gap between funding, between regular funding and continuing healthcare, and keep residents in their homes. So what we took from that mandate is that we need to find some funding that sits in the middle, therefore the slightly more complex patients that aren't continuing healthcare. but also how are we going to keep residents in the home when they've got more complex conditions. So what we took away from that was that we need to do something around upskilling the homes and have more wraparound services and better comms going into the homes. So the first thing we had to do was build a project team, and this is where a lot of the integration work comes in, because a project like this has to have local authority representation, it has to have clinical commissioning representation, and it has to have a link with the actual providers themselves. So you'd need a project manager, you need someone from a commissioning level from the local authority, in Hertfordshire we have an integration manager that works across the local authority and clinical commissioning group. We use the contracts manager from the local authority, we use the quality lead nurses from the clinical commissioning group, and we have the providers association. So that's how it all links together for us, and we saw that that's what you need to make a project like this work. So in terms of what we did, so we've received our mandate and we've got our project team, we know what we need to figure out. Then what we started to do was to look at what is our problem in Hertfordshire, what are the main reasons that people are being admitted to hospital, or what are the main reasons why a GP is being called out of hours. So the quality lead nurses from the clinical commissioning groups across our county went to review their care homes across the county. I'm not sure I mentioned this earlier, if it's of interest. In Hertfordshire, we have around 260 residential and nursing homes split across 2 CCGs. So we were working together at this point. And so they went away, reviewed their residents, collected in the baseline data. Then we reviewed the baseline data, and what initially came out as the main reasons for services being used. The source for the baseline data is we collect from acute, have the reasons for admissions, GPs share the reasons for why people are using services. So that's where we got that information from, and that is fed back to the quality leads, because then previously, before this, they would already have been receiving that data, because they would have to be going into the homes anyway to work with them on those areas. So what we found, the main reasons for the use of services were around dementia, falls, nutrition, tissue viability, continence, respiratory conditions, neurological conditions, end of life, and bariatric care. Now, the plan was we wanted to turn these into champion pathways, so that you would have someone in the home that could champion that area. We did feel that end of life, continence, the neurological and the respiratory, they were slightly smaller than the other areas and probably wouldn't create a whole training package. So at this point, we packaged them together in what we called the health pathway. With regards to the bariatric care, we made the decision to not pursue that at this point in time, but look at it as continual professional development for one of the champions at some point. So that was the list that we created, and that was Hertfordshire specific. That was what we had at that point in time, 2.5 years ago, of what were the main issues for admissions, A&E attendances, emergency GP call-outs, etc. So that's how we analysed the information. So from that, we know what areas we need to tackle. So this is where I'm going to move on to our development timeline, because what we created from that point is we needed to know how can we turn just knowing that dementia was one of the main problems into a training package that then would upskill homes. So the first thing that the quality nurses started work on is what we call the characteristics. The characteristics pulled out the competencies that would be needed to train that, what were the fundamentals you needed in a home to deal with that. I'm going to show you the characteristics document in a second, but I'll just run through the timeline first. So firstly, we created the characteristics. Then from the characteristics, we were able to develop the training for each of the individual champion pathways. Then we were able to develop a job description for the champions who would be doing the champion pathway. And then we also had our some other elements that I will come back to shortly. What I'm going to do at this point is switch to some documents where I can talk you through how they were developed and what's involved in them. So just to clarify, we talked about the advanced champion pathways that we run, so that you have one champion with a certain subject matter cascading knowledge through the home. Then for when we started developing the complex care premium, we found our 5 pathways that we wanted to run: dementia, falls, nutrition, tissue viability, that for the rest of this presentation we chose to change it to wound management because a lot of the residential homes didn't understand what tissue viability was, so we made the change to call it wound management. And then we wanted to develop our health pathway, which would include end-of-life care, continence, neurological and respiratory conditions. Then at this point, then the quality lead started developing the characteristics. So now I'm going to change the screen for everyone and share my screen. So what you will see on the screen hopefully in a second, this is the characteristics document that the quality lead developed. It runs through each of the areas so that we've previously mentioned: dementia, falls, nutrition, wound, health. What it does is it breaks them down into residential and nursing, because we wouldn't expect a residential care practitioner to undertake the same tasks as a nurse. So on this first screen, where we're looking at nutrition for residential, you'll see that the first column is infrastructure. So what really the infrastructure column is about is what does the home need to have in place to best care around nutrition. So are all their policies and procedures regarding nutritional care up to date and evidence-based? Do they have the correct equipment? Do they have the right catering arrangements? And can a home evidence that it undertakes nutritional audits? So that's your infrastructure element. Then moving on from that, you've got a column that says competencies. Now, this column, this is really your outcomes that you'd want for training. So if I was to read through these ones for nutrition, you have staff knowledge of healthy eating in old age. Staff have knowledge of nutritional problems in older people and different strategies to address these. Staff have knowledge of the provision of special diets, and so on. So those are the competencies that someone who is going to be a champion needs to know about to best care for residents with those problems. So what we're able to do from that is then you've got your infrastructure in place, you've got your competencies, and then you can develop the training and support. So what we would then, then you've got the column next to that that is training and support. So as you can see, if there's training, what would we do to achieve those competencies? Well, we are going to do an advanced nutrition champion pathway training. And then from a support perspective, we have the likes of the dietitians, the district nurse, the SALT team, the GP and the pharmacist. So that's then from that, what type of resident would need this type of care? So someone who had difficulty swallowing and would require one-to-one support for all meals and drinks continuously and has a must score of 2+. So they're the type of residents we see needing the high end of this care and knowledge. However, they're the people who are complexities, but from my perspective, I see that this training will benefit anyone in the home. So then our final column, we've got the outcome measures. So we hope to see more increased referrals for the SALT team, reduction in the number of patients losing weight, and compliance with weekly weight monitoring. So they're the types of things from those competencies. If they were to improve, we would see those outcome measures improve. Now, now I'm scrolling down the document, you can see that it then goes, the columns are exactly the same in every single area. So you've always got your infrastructure, competencies, training and support, type of resident, and the outcome measures. So that was nutrition. If we scroll down, you can see that we have the wound management as well. For both residential and nursing, we have dementia. I won't talk through all of these in detail. We will be sending these out so that you've got them for reference. But the key is this is Hertfordshire specific, because we've looked at our analysis and said that we need a dementia champion. Some areas of the country may not need a dementia champion, so it is important to localise what you need. So then we go to falls in orange, then we have neurological, continence, end of life, there's respiratory, I said it a minute ago, really wasn't watching properly, and then mental well-being. So mental well-being, although that hasn't been mentioned before, we feel it's important that engagement and well-being should be a big part of any training package if you're trying to change a way a home runs and the way they work with their residents, and that in what you would call an activity coordinator needs to be a crucial part of that team and working with everyone. So that is our characteristics document, and it's from that that we were able to develop our training. So we knew what we wanted to improve in Hertfordshire, and then the quality teams were able to tell us exactly what competencies someone would need to care for someone with those complexities. So from that, I'm going to switch to another document now. This is what we call our delay. There may be a delay while it's changing over. Sorry, there's a delay as I'm moving through the document, so I just need to wait for a moment. So now you should all see a screen that says working with the CCP team. Now, what this document does is I'll go to different places. What we then had to do was work out what we needed to develop the training packages. Now, we worked with a number of different training providers on this. So for the specialised areas, like the continents, it made sense to use one of the training nurses from the bladder and bowel team in the Hertfordshire community teams. So we worked with them to develop the training packages, and the tissue viability nurses we worked with to do the wound management training. For things like the falls pathway, we have some approved training providers that do very specifics around moving and handling and falls. So we worked with them. So our previous work where we'd have our approved training providers helped us with this section because we already knew the right people that we wanted to go to develop the training. But what the characteristics document was able to give us was the outcomes for the training. So once you've got the outcomes, a training provider can develop the training package that you need for that. So if I'm scrolling down now, and hopefully your screen will catch up with me eventually. Should do in a moment. So I'm just waiting for the screen to catch up with yourselves. Sorry, it's going quick for me, but not quick for yourselves to see what I'm looking at. I'll start talking through it though. What this booklet does is it breaks it down into each advanced champion area, and in each area you'll see a course overview and a job description for that champion. So for the dementia champion, we pulled out of the characteristics that we need to be doing training around dementia awareness, we need to be doing training around behaviours that challenge, around environments, around positive interventions, around working with challenge, making connections, and intimacy in dementia, antipsychotic meds, mental capacity. So what you'll be able to see in the document, which you'll get after this because it's going very slowly, so you won't be able to see it, is the outcomes for that training. So if I give you an example, I'll read it out, these are the outcomes for the dementia and environment training. So, it's on your screen now, so you can see the fourth box down is dementia environment. So those are the outcomes we were able to pull out of what we need around, what we need a champion to be trained in around dementia and environments. So the first one being, explain why changes to the physical environment must be evidence-based, explain how good design promotes self-identity and self-esteem. So we would give those outcomes to our trainers, and then they would work out how long that training was to deliver, how they're going to do it, what activities. Now, in some cases, what we did with the trainers is obviously the characteristics don't go into that much detail of the outcomes, so we would maybe have to delve a little deeper. We're lucky enough in Hertfordshire that at this point in time, we have very good relationship with the training providers who are all specialised in their areas. So from the characteristics, they are then able to go, okay, so if you want to improve dementia environment, these are the outcomes, this is what I would need to train on so that someone would be able to pass on knowledge of environment. So I think the key here is working with the correct people who have the correct knowledge rather than just any old training company. So that's how we were able to develop our training courses. And then you won't see it just yet, but I'm scrolling down to what we call a job description section, because once we know what we need to train the champions in. We know the training providers are creating those training packages based on the outcomes. Oh, you're on the screen now. I have to keep looking back to my colleagues to see if you're caught up with me or not. So then what you do want, though, as a manager of a home, is to be able to embed what that new champion has learned into their job role, because the big successes of this project, it's not just about someone learning something and then passing it on as and when. You want this person to be the go-to person for that subject area. You want them to be able to train, you want them to coach, and you want them to mentor. So what we thought was helpful for the champions and the managers was to create job descriptions that they could follow and embed in their own job descriptions ongoing. So for this one, the main purpose of their role as an advanced dementia champion is to use their skills and knowledge to promote good dementia care, to make sure the service has a dementia-friendly environment, and to create a continuous dialogue with professionals about antipsychotic medication concerns for individuals supported. So that's the main purposes of the role, and then we went into specific responsibilities. We created the specific responsibilities out of the outcomes of the training. So if that's what they're being trained to do, then they can also have that within their job description as something they pass on. What we also thought was useful for the managers was to also link that to key performance indicators. So we created these per champion. So for the dementia champion, we made that so that the manager could track how many training sessions are they doing, how many mentoring sessions are they doing, how many coaching sessions are they doing, have they got less use of the mental health team, are they got less admissions, outcome strategies implemented by the CCP team, are they met, and any changes made to care plans. So they were we've given these to the managers as an idea. We don't say that they have to use these, but what we found when we started was that actually, well, before we started, that if we gave the tools, it would probably be easier for them to move on. So that is the document on, and then it won't catch up with me now, but what you'll find is you've got that same for every single pathway. You have the learning outcomes, you've got the job description for that champion, and you've got your key performance indicators. So for dementia, falls, nutrition, wound management and health, you have got those three elements that we developed from the characteristics with our training providers and specialist nurses within Hertfordshire. Now, what we then end up with is what we call a CCP team. So we've got the document when it moves up to catch up with me, is we want all these people to work together. Your home, once you start training, you end up with 6 champions. You have your dementia, wound, health, nutrition and falls, who are doing formal training, and then we have the engagement champion. Now, I haven't touched upon the engagement champion yet because they don't do the advanced pathway training like the other champions. We feel that engagement and work with activity coordinators should take place in the home, because then we get a much better idea of what's actually happening. So I will touch upon that more a little later of what we do with the engagement champion. But in terms of the complex care premium team, you end up with these 6 champions plus a manager who can all work together, because it's very unlikely that you will have a resident who has a complexity just in one of the areas. It's very likely that maybe someone who's got issues with falls may also have issues around nutrition. So it's about bringing those together and giving those opportunity to talk about their residents. So that's a brief part on the complex care team. I'm going to slide back. I will send around all these documents for you to review. They're quite large, but they do really outline everything that we cover in our training and everything that we expect a champion to do. So I will now switch back to how do I get? I'm just working out how to get back onto the WebEx.
The drop-down list that you're looking at, on the left-hand side it says return.
Lovely.
That's
Thank you, Paul. So that was to just go back over. I'm going to go back one slide. So we did our analysis. We worked out what complexities we needed to train on in Hertfordshire. We worked on the characteristics document to work out exactly what competencies a champion who was going to champion that area and cascade knowledge and work with residents would need to know. Then we developed the training from the outcomes. Then we were able to develop a job description for that champion. So that's the work we did really development-wise around training. So the other bits that we developed were an exercise program that we wanted to deliver in the home around reducing falls. I am going to touch on that later, so don't worry if I don't say anything about it now. And then we also had to develop the finances and the contracts process, because I have not mentioned it yet because I didn't want to create any confusion, but where we mentioned that we wanted to bridge the gap between normal local authority funding and continuing healthcare funding for these residents with complexities that fall in between. What the hope was that when we've got these champions, so you've got your dementia champion, you've got your falls champion or whoever, is that if the home is taking on more complex patients and they are caring for them at a higher degree and they're not using health services as much, we want to fund them a higher amount of money for that individual resident with those complexities. So the idea was that we could give extra money for, say, someone who's got someone with severe pressure ulcers, and if they've got a full wounds champion in place and can properly care for them, then they could get additional money. What I'm going to hand over to now is Coolbeer, who's from Hertfordshire County Council, who is the, remind me of your job title, Coolbeer?
Afternoon, everybody. I'm Coolbeer Ali, Head of Integrated Accommodation Commissioning at Hertfordshire County Council. We've been working closely with both HCPA and East and North Hart CCG on this project.
Yeah, lovely. So what Coolbeer is going to do now is talk you through how we worked on the contracts and payments and the monitoring in terms of this project.
Thank you, Michelle. Good afternoon, everyone. Just to kind of recap on the point that Michelle was just touching upon there, we've identified a key gap between the local authority funded care rates and the beginning of the continuing health care rates within Hertfordshire, and we recognise that that was a significant gap in resources, both monetary but also staff resources as well, to enable care homes to care for these people that kind of we're on the cusp of being eligible for continuing healthcare, but we're being maintained and supported within residential care homes under residential or nursing fee rates. And part of the thinking was about, in terms of filling that gap, the approach was to how can we best invest in the workforce to be able to meet the needs of those people with that higher degree of complexity in the way that Michelle has described through the training processes and the various different pathways that the workforce and the people within the homes could access, is to try and identify how that would work and to really invest in that care workforce to prevent hospital admissions that aren't necessary. So just to start off on this slide, I think the first point to make was that there was no fixed starting point for this particular financial model. As with all things, it started off with a few assumptions that we had to make, and then test out some of those assumptions, and then to roll that out in partnership with both HCPA and the CCG with our providers on the complex care premium project. So the assumptions started off in terms of the conversations around what that premium would look like. The initial figure that we started to work off was a £50 per week premium, which intuitively felt like the right amount, but obviously that we had to kind of test it out a little bit further, and we had to make some assumptions, which are summarised on the box at the top of the slide there, to get to the £70. But in essence, how we calculated the premium and how we got to the £70 premium that we are currently at is using the fair cost of care model, making some assumptions based on a 45 bedded care home with 45 residents, assuming a certain staffing ratio for 12-hour shifts, and as the table across the top of the slide shows, that working that out comes to just over £112 per week for that core staff group. Now, the next assumption that we made was how many people would we expect in that 45-bedded home to be eligible or to be receiving a level of care to meet a certain degree of complexity of their care needs. So the first thing we did was set an assumption around a 15% figure of those 45 residents. So then splitting out those 44 residents into a group of 37 and a group of 8, we recalculated the figures, and we worked out what the care rates would be for those 37 residents at sort of a fee rate of what you would normally expect within a care home. And then we reworked the ratio again for the 8 residents that made up that 15%. But what we did there is we increased the staffing ratio. So another assumption we made was that actually, rather than a 1 to 6.5 staffing ratio, we would expect people with the sorts of complexity that Michelle's kind of highlighted already would probably need a ratio around 1 to 4 to be able to support their care needs in the way that we want providers to be working and the investment we wanted to put into care workforce. And when we calculated that came up with a figure of £181. And then we looked at the difference between the two rates. So the 37 residents that would be non-complex and the 8 residents within that 45-bedded home as complex. The difference between the two was £70. And that was what was kind of put forward across all partners as the basis on which to proceed with the kind of the payment element of this project. And obviously that was presented and shared with providers beforehand, and actually that was a welcome figure. The methodology, whilst based on assumptions, the methodology did stack up to questions and scrutiny from providers, and actually what providers were worried about in terms of the ongoing viability, they felt that was covered off in the way that we'd calculated the fee and the £70 premium. In terms of how that relays itself back into the contractual arrangements, linking into the training and the payment elements of this, once providers have completed the various different pathways that you've already kind of been talked through, that involved, from a contracting point of view, a variation to the existing contracts that we had with these homes. introducing certain elements and criteria for the complex care programme that we were looking to introduce. So in addition to managing people with a higher degree of complex needs and looking at particular, I suppose, areas of expertise within the home around perhaps dementia or nutrition or falls, that we could build in certain requirements, looking at those sorts of various different specialisms, but also looking at things like how else can we help the system. So we started to build in key performance indicators around hospital readmissions, hospital discharge delays, and also introduced the concept of weekend admissions as well, because we felt that the training and investment that was put into the workforce in those homes would allow the overall system to perform more efficiently, but also that the home would be able to respond to that through the various different training needs and expectations put in place. We were looking for outcomes over and above what we would normally expect a care home to be delivering. So the way that works is that the contract variation recognised that actually, in terms of looking at the claiming criteria to see who is eligible upon admission into a care home for the complex care premium, we took a trusted approach. So whilst we were expecting care homes to operate on a trusted assessor model, we also agreed to operate on trust in terms of claiming criteria, and it is the responsibility of each home to assess the individual in their care against a set of criteria based on the training and the complex characteristics that have been developed. And homes would then indicate which of those complex criteria that individual's needs met, and therefore they would be eligible for the additional payment of £70. That information comes back through the contract manager for the contract, and we do kind of regular background checks, so just checking initially to make sure all the information is there, present, it's correct, and everything is filled out in such a way that gives us the information. But we also then do spot checks in terms of interrogating further 1 out of every few criteria claims that come forward, to really drill down into the detail to make sure that the payment and the criteria are being met, and it's grounds for releasing the payments. The payment schedules have been set up for each home based on the number of residents in their care that meet the complex care criteria, and we pay that as part of our monthly payroll run, which is an additional £70 per week per resident, and that is now fully automated into our payment processes. In terms of then understanding how all that works from a contractual perspective, there is a number of different things we need to consider when monitoring the effectiveness of the care being delivered. So in addition to the quality of the training, the physical training being delivered, which is also monitored, there is a process to undergo checks within the home once those admissions have been made. And these monitoring arrangements sit alongside our standard monitoring arrangements, Hertfordshire being one of 11 East of England's local authorities. We use standardised tools for monitoring. So we've built in, for those complex care premium homes, some additional questionnaires, questions, relevant checks into the process, so we can pick up through routine monitoring visits, but also we can have a real focus on particular homes to have a look at a particular area of expertise. For the homes within the complex care premium, that is triggered by the admission process based on the information that we receive that show why the home feel that person is eligible and meet the criteria for their complex characteristics. The next step then is to do a series of kind of announced and unannounced spot checks. So that's both in terms of the Hertfordshire Community Services, so adult social care services quality perspective, but also from a clinical commissioning group perspective to have a look at the clinical elements of the training and how that's being embedded. So those quality visits tend to speak to the complex care team within the home. So that's the group of people that have received the training and are actively managing and leading the home through this initiative. Looking at practice, both observed and written in terms of the impact it's having. And also, as I mentioned, looking at clinical intervention. So looking at issues, things like catheter care, are the staff implementing the training in the right way, and are staff able to cascade and share that learning to the staff group within the home itself. Those quality monitoring visits allow us to do two things. It allows us to pick up and identify issues there and then at those visits, to be able to speak to either the relevant champion or the manager in understanding areas that we feel could be improved, and feedback, advice and guidance is given there and then on the spot. The other element is to understand the overall impact the complex care premium is having on overall performance within the system. So looking at things like readmission rates into hospital, broken down into things like admissions and attendances, looking at recruitment and retention issues within the home as well, because one of the key reasons for investing in the workforce in this way was to address the issue we've got around workforce retention and recruitment in Hertfordshire, and recognising that in some cases there was a skills gap where we were looking for care for more complex people with complex needs. All this stuff that we've pulled together from the Adult Social Care and Clinical Commissioning Group quality visits is fed into a performance dashboard. So in addition to the things that we've already mentioned, it starts to have a look at rating the performance of the home based on the number of beds it may have, the sorts of services it generally delivers. So for those units, for those services that deliver nursing care, for example, we would expect to see slightly different performance to those homes delivering residential care, because one has a core group of nursing staff on site and the other doesn't. We're also looking at the ratio of the home size in terms of the number of readmissions per population size for that home, so that we can start to break down and make like comparisons between a 150-bedded care home, for example, and a 20-bedded care home, so that we can start to interrogate some of that performance and to understand that actually if both those two homes had 10 people going in to A&E, actually it's probably more of a concern potentially for the smaller home, given it's a greater proportion of the number of beds within that home. We then look at that performance information to try and understand what individual issues those individual homes are facing in terms of their interaction with the wider health and social care economy in Hertfordshire, and with the view to develop and put in place individualised and tailored improvement plans for that individual home based on their particular issues, so that we're able to really support the staff group there that are part of the complex care premium team and the management structure within the home to understand what their work is showing and what it's delivering, but also to highlight and point out areas for improvement. So one of the things that we've been looking at is looking at those homes that have got a high difference or a large difference between A&E attendances and A&E admissions. The thinking being that actually, if the larger the gap between the two, the more people are going from an individual home to A&E that aren't being admitted and are returning back into the care of that individual home. So looking at some of that performance data, we're able to go back to homes to offer them a bespoke improvement offer related to the specific issues within that home. So whilst the trends might indicate there's a large gap between attendances and admissions, the rationale and the reasons behind that are very different for each of the homes. And we've got a number of examples of where we've identified issues, some of which were in the control of the home, and some of which weren't in the control of the home. So we've had some instances of where, having gone in and understood that data and had a conversation with the home, we've had one example of where an individual resident with a mobile phone was making calls to to A&E, which was skewing their performance figures, but actually having the ability to drill down and have that conversation with the service, we were able to take the right steps, and the home was able to reassure us that they were taking the right steps. We've had other instances where the interaction between the home and other health services or other support that they were expecting as part of this program either haven't materialised or have not been implemented in the way that was initially thought out. So we're able to take that information away and pinpoint the support that's required. So that might be greater pharmacy involvement in terms of the issue around medication. It could be building relationships with the local GP practice so they can have those phone calls and conversations with individual patients, to wider issues around 111 calls and the advice that they're given. So it's given us a real rich stream of information that we're able to go back and speak to individual homes and look at individualised improvement plans. And I think for us, in terms of the monitoring and that feedback loop going round, I think we've put the kind of the generic training in place, which is getting a large number of staff to get a large number of skills to be able to start to deliver and implement within the homes, but recognising that it wasn't going to be an easy transition, and actually by developing those bespoke and tailored improvement plans for each of those individual homes, we're having a greater impact in terms of addressing some of those issues, but also something that's meaningful for the environment within each individual home. Thank you.
Just before we move on to our next poll, in terms of finances, this project originally started with the Better Care Fund, and that's where the complex care premium started. So that the Better Care funds the premium payments, and it funded the initial training, and now it's still the Better Care Fund that funds the premium payments at this point in time, and it's the Vanguard program that funds the training at this point in time. So now we'll move on to another poll, which I'll let Paul introduce.
Okay, thank you for explaining all of that, really helpful. So the last poll, and after the poll, we're just going to take the questions. So whilst people are completing the poll, my colleague Sue Wales is going to go through the questions you've been posting on the chat, so thank you for that. But let's flip over to the poll. I'm just going to open the poll, and same as last time, 2 minutes for people to respond. Okay. And just to confirm that the poll will be on the right-hand side bar. So if you're having any problems, if you go to the top right, and there'll be a tab that that looks like some charts. If you click on that, and then that will expand your polling aspect. Okay, thanks for the feedback. I understand there's some issues with people only being able to click one. I'm just going to pass over to Paul, our IT specialist. Paul, are you able to help people with just clicking one option?
Give me 1 second. I'll quickly take the presenter's ball back and reset it to make sure that you can do more than one.
Right. So thanks for everyone for letting us know they're having the problems. We're just going to reset. Just bear with us, and we'll restart the poll.
Could you just stop the poll so I can take it over, please?
Sure.
Yep. Thanks. It won't let me take over the presenter's rights until you've closed the poll.
Okay, it should be, it was counting down a moment ago, so it should be...
right, okay.
Right, okay.
Got it, thank you.
Okay, what we're going to do, just whilst Paul's just working out the IT issues, we're just going to look at a few of the questions.
It should work now if someone wants to test it.
Actually, Paul's been extremely swift with solving the problem, so the poll is now open again. Can we reset the time, Paul? Because it's just giving people time limit. Yeah, that's fine. Okay, brilliant. So if people could just, apologies for the issues, if people could just submit again, and let's just see.
Yeah, despite being set as multiple choice, people are still saying it's only allowing one in. So if people just put in their top answer.
Yeah.
Okay, I'll close the poll and share the results with everybody because most people have answered now. And you should now be able to see the results. And so by far and away the highest feedback was dementia.
Okay, so thank you for talking that out, Paul. Thank you for everyone being patient with us. And for everyone filling in the poll. That's quite an interesting one with dementia, and interestingly, it ties in perfectly with one of our slides further on. Okay, so as promised, we're just going to go through some of the questions people have been posting in the chat bar. I'm just going to ask our colleague Sue, who's been keeping an eye on them, just to summarise them for us. Over to you, Sue.
Hello there. Okay, I've taken some of the key themes that have been coming through on questions. First of all, going back over the champions themselves, sorts of questions are, how do homes pick who their champions are going to be? Are there any criteria for people that can come on the champion training? Clinical, non-clinical, anybody?
Well, we say if it's a nursing home and say it was the wound pathway, ideally that should be a nurse completing that because they're going to look at formulary. But other than that, even if it's a nursing home, it doesn't have to be a nurse completing the training. I would only say really for the wound pathway. We have a kind of general criteria for the champions. One, that they should be picking someone that has the confidence to talk to other staff and train. We should say they should be on around a level 3 diploma kind of area so that they can do that level of work and that they will have the ability to supervise staff. So that's the criteria we really set, that they should be around about a level 3, that they should be able to supervise and that they have the confidence to train. Because in the past when we've done this, we've really found that if someone may be fantastic and be able to take in all the knowledge, but if they can't pass it on, there's not that much point of them being a champion. So that's really the criteria.
Lovely. Another question related to the training. You answered before who pays for the training, but equally, what is the cost, therefore, of the training? Almost of each champion, perhaps?
The cost has varied over time as we've changed things. The overall, for the complex care premium, so for all the training and the beyond the armchair exercises, it was around £17,000 with all the training combined. I don't have the exact figures of what each training package cost, but it is a high amount, so it was written into their contract that if they dropped out, they would have to pay back penalty charges for leaving the project because of the high amount. And it's a high amount of money because it's 6 training programs that are around 12 to 18 days each, including qualifications plus work in the home. So it's quite a considerable amount of money.
And that's per home then?
Per home, yes.
Lovely, thank you. And that relates to...
and it was funded by the Better Care Fund initially.
Lovely, thank you. And then related to that as well, it was to do with the validation of the training, because you mentioned training providers. So do they provide the validation of the courses they deliver for your staff?
So if we're talking about qualifications are validated by an awarding body. So there's various awarding bodies, but Edexcel, Ofqual, people like that. So a training provider will be associated with an awarding body to do their qualifications. And then in terms of just your knowledge training, we check the competency of the trainer against what they're able to train, and then check that someone has the competency for that. So with the continence training, you have the bladder and bowel nurse. So we've checked against their competencies that they can then check that someone understands what they've trained and to deliver the training.
Yeah. And another, sorry, we'll cover these, so I think these are relevant now, right, because they won't be covered later, but how have homes been able to free staff up to come on this, or has that been part of the way that you've implemented it to help them with that?
Well, we try to, spread out the training so you're not having more than one person out of a home at one time. Additionally, we pay £5,000 backfill to each home that was calculated when we looked at the amount of training days and the cost per staff for a day of training, and worked out that by paying £5,000 backfill cost, they could use that where they would need extra staff in to cover if necessary while people were out on training.
Okay.
Thank you. If anyone has questions for the rest of the session, please do put them on the chat and we can ask them at the end.
Okay.
Thank you.
So we're just going to go into the final part, which is delivery and impact. So I'm just going to hand over to Michelle, who will talk us through that.
Okay. So now what I'm going to talk through is our delivery and engagement timeline. So we've developed everything. Now we actually have to put it into practice. So what we started by doing was engaging with training providers, so the people that were going to deliver this. So that was where I worked with them, created all the lesson plans, and started booking in dates for the training. So that was the first step. We couldn't engage with anyone until we knew exactly what we wanted them to engage in terms of dates and the training package. So then once we had that all in place, we were able to then start engaging with the homes. We started this in the training didn't start till April 2015, but we actually started engaging in December 2014. We started doing general, just e-news shops to just try and get people's interest. Then we did general information meetings where people could come along and find out about the project. And then what we did from that point onwards, then homes, if they were interested, they've looked at all the dates, then they could start, then they could sign up for the training. So we had an application that they could sign up for. On that application, they had to outline why they thought they should be part of this project, and also touching on a question that was just before, they also had to outline how they were going to cover in their homes while staff were out on training. So we wanted to see how they were going to combat that issue. So once we had homes sending in their sign-ups, we were able to review them as the project team that I mentioned earlier on, to look at which homes were applying. We looked at things like their local authority monitoring scores, we looked at their CQC scores, we looked at just general information as a group we had about those homes, and we also looked at their position in the county, because we didn't want all our complex care premium homes to be in one place, because your desire eventually is this home is going to be able to take more complexities. You don't want just it to be in one area of the county that can take certain complexities. So then we reviewed all the homes and we picked which homes we would like to take them forward. Then at that point, the contracts team at the local authority started amending contract arrangements. So then we've got our homes signed up, we're working on their contracts, then what we need to do is some pre-evaluation with them. Where are they currently at? So what are their current admission figures to hospital? What are their current falls rates? What are their current staffing capacities? So we started gathering in that information. Following that, the training ran between April and December, so it ran over 9 months in 2015. We did have a gap in the summer because it's silly to run training in August time because no one can attend. So we ran the training then. We have subsequently, when we've run Complex Care Premium again in 2016, I adjusted the way we did the training slightly so to make it even easier for champions to attend by having the pathway start in a kind of domino effect. So you would have your nutrition pathway start 1 month, then your falls pathway wouldn't start until a month afterwards, and really making sure that no champions were out at the same time. In the initial phase, we had 20 homes take part in this project. We had 6 nursing homes and 14 residential homes across the county, because when we originally did this project with the Better Care Fund, the first 20 homes, this was a 2 CCG project. So we worked with the west of the county and East and North Hart CCG. Now that we've gone into 2016 with the Vanguard Care Home project, now this is just now we're just working with East and North Hart CCG homes, and we're doing some other work, different work away from Vanguard on the other side of the county. So going back to the timeline, we had our training happening, we'd already collected our pre-evaluation. Then throughout the training time, this is where in the home we would be working with the engagement champion. Now we still call them a champion, but what we do instead is we work with them in the home doing direct mentoring to take them through a qualification in engagement practice in the care setting, which is a level 3 qualification. So we did that in the home through mentoring over 20 weeks while the training, other training was happening. We also have our Beyond the Armchair exercise program, which I will look in at more detail after this slide, but what it is an exercise program that ran over 6 months with a class each week that was exercise with 10 residents to reduce their falls risk. So all of that was happening at the same time. The training of the advanced champions coming out to train, the engagement mentoring with the engagement champion in the home, and the exercise program were all happening succinctly. Then when we got with a premium payment started in 2 phases, we because by the time we'd got to August time, around the homes had completed a number of the pathways, so they could have completed the dementia pathway or falls pathway, for example. So for those areas, if they wanted to then claim the extra £70 uplift per week for a resident that met the complexities of falls, they would then be able to claim that because they've met their criteria of having the training and putting everything into place. So where it says premium starts, it started for the ones where they were eligible to start claiming for. Then, so once they've finished all their training, and that's where we expected them to start working as their CCP team, as previously mentioned earlier, where we want them to work as a team, look at their residents, what are they going to do to prevent certain complexities happening to residents, or what are they going to do to resolve issues of certain complexities that a resident already has together. So when those meetings happen varies. It depends on the size of the home and how many residents they have with complexity. A large home was doing them once a week, looking at certain residents, getting feedback from other staff members, what did they need to put into place. So we developed some very simple case notes templates that they could go through for that resident to pick up what their plan of action was for them. What we also expected them to doing at that point is they finished training, so we wanted them to start doing their own internal training at their home and also start mentoring and coaching within their home. So by the point it had got to December, this was really the point when they should start cascading their knowledge through the home and really starting putting action plans and prevention measures in place for residents with the complexities. then since December and up until now, we've carried out intermittent support visits. What the support visits really were is to go out, see how the champions are getting on, see how the managers are getting on. Are there any issues that we need to resolve or they need support with? Are there any champions that maybe are feeling a bit low in confidence around a certain subject area? What can we do? Do we need to get someone, do they need to attend any additional training, or is it just that they need some more confidence to get up and train within their staff teams? But also what we would do is sit in the team meetings at the complex care premium team meetings. We would sit in those, see how they were action planning for their champions. So that's been, we are still continuing to do those meetings. And then what we had after their training is we also wanted to carry out some evaluation. So we've done our pre-evaluation, now we're carrying out our post-evaluation after the training, which happened at different months. Went around about over 4 to 5 months that we were doing post-evaluation for these specific pathway areas. And then what we've just finished about 2 days ago is we've done a final evaluation visits on the projects. So we're still looking at the results of those, but what we really wanted to pick up from those final evaluation visits is to look at the other evaluation we've done on the individual pathways, and then also bring that all together, find out how much they've been doing since then, and then additionally look at other things like, has their vacancy rates changed, have their staff turnover rates changed, have their complaints measures changed, so that we can see the impact that this project has. I will in a few slides time look a bit more at evaluation. In terms of the premium payments, that the contract we had with them ran up to the 30th of September 2016 in its current model, which was the £70 per week for the complexities. We have reviewed that method, which we will touch upon at the end in our lessons learned. So moving on from delivery timelines, we've now got a short video. I've mentioned a few times our exercise program that we run. Really what the Beyond the Armchair exercise program was to see if we could reduce falls risks with exercise. We used what were called Q-tugs, which are measuring devices which a resident would wear. They would walk up and down, and then this system was able to measure what their falls risk was. So we used those to see what someone's falls risk was before they started the exercise training, in the middle, so 3 months in, and at the end. So what I've just posted in the chat is a link to a YouTube video so you can see an example exercise class, because I think probably the best way to explain it is for you to see one of the videos. So we'll have everyone have 3 minutes to watch the video that I've just posted into the chat. It's just in the chat box on the right hand side, you'll find a link to the video. I'll post it again because there's another comment so you can see that it's the newest thing in there. So we'll give it 3 minutes and we'll start again. I think that everyone has had time to watch the video now. We'll have to send the link again if people haven't been able to use it, because it has worked from our point of view, so I don't know technically why it maybe doesn't work on other people's computers. As I say, it might be the browser or your bandwidth. So if we start moving on, we will send the slide again afterwards. But really what the exercise class 4 is, we wanted to see if we could improve falls. So on the next slide, these are our results after 6 months with our 20 initial homes that we did the programme with. What we found in the initial phase was residents that attended less than 50% of classes, you wouldn't have seen an improvement. What we've changed when we've run the complex care premium again is a bit more of a criteria of who should be attending these classes. In the initial wave, why we had some low attendance in some classes is some people with particular behaviours that challenge around dementia and some people on end-of-life care were picked to do the exercise classes. And if you want to see if it has an effect on falls, we needed to go with other residents for this particular project. But what this graph shows you is the orange line is the pre-scores for the residents that attended over 50% of classes, and the blue line is the post-scores. So as you can see, their falls risk has gone down. So we found that actually consistency in attendance in the classes, that falls risk did come down. What we were able to give in between classes were small exercise programs that the activity coordinators or the falls champion or members of staff could do individually with the residents. You cannot do a full training class of exercise with residents without being trained to do it, which is why we left individual plans that they could do one-to-one with residents. What we're doing as continual professional development for the homes is giving them the opportunity to train to do these exercise classes themselves within the home. So that's our Beyond the Armchair exercise programme. Along with the Beyond the Armchair exercises was the engagement mentoring programme, which we've mentioned, which is for the activities coordinator, as it's largely called in homes. We use the term engagement because engagement in homes shouldn't just be about running activities classes. It should be about one-to-ones, your day-to-day engagement with people, not just the activities that are happening. So that's where we've done our 20-week programme with the engagement champion, where they will work with one of our mentors who can look at specific things like understanding the difference between activities and engagement, action planning to improve engagement, person-centred care, Allen cognitive levels around dementia, how to pass on their knowledge to other staff, policies and procedures. So they studied quite a lot around the engagement side of it, which then meant they were a champion at the end of it. So moving on, we'll look a bit at evaluation. So we evaluated the project in a few different ways. We firstly did our impartial feedback service. Now, I mentioned this at the beginning about you could become a gold member of HCPA if you did the impartial feedback service. All of our complex care premium homes were expected to do the impartial feedback service. What it would be was we would give them surveys which related to the key lines of inquiry of CQC. These surveys would go out to staff, families and friends, residents and professionals. Once we got over 50% of returns, we were able to run a report to see how well they were performing in those areas. So the surveys came back to us rather than to the homes themselves, which is what made it impartial. So that was the one service that we ran. On the next slide, I will show you now is this. What this chart is one of our example homes. So you've got safe, responsive, caring, effective and well-led. So the 5 key lines of inquiry. And what the blue line is what they scored overall in their surveys before we ran the complex care premium. And orange is where they came after. So what we were able to see that we did see an improvement after the complex care premium was put into place. So then what we also did is we did pre and post course questionnaires for each of the pathways. These largely looked at, these were very simple online surveys to find out what they were currently trained in the homes, what people were currently passing on, what knowledge they currently had. So we could get a basic idea of what the champions and the homes already did in those pathway areas. We also did what we called impact evaluations. So these were mainly on a set of standards. We'll send out some example copies of these following the WebEx. But I'm aware of the time and I know that I can keep talking forever, so we will send out some examples. For the impact evaluations, we created one for each pathway, and really they set a set of standards that met with the characteristics we talked about earlier and the training outcomes that we should see changes in. So we did an initial impact evaluation and we did a final impact evaluation, so we could see the changes that were put into place following the training. We did obviously the QTUG assessments for the Beyond the Armchair exercise. We did behavioural assessments for the engagement champions to see how their behaviour changed from the beginning to the end, and we also do ad hoc case studies. So as well as what we've done evaluation-wise, we also have some external evaluation where we have medi-analytics, which we're going to touch on shortly, which is a lot around our admissions to hospitals and A&E attendances and use of services. And we also have the London School of Economics, who are going to be doing an evaluation on the project now, and they're going to be looking at a lot of things like how has it affected staff capacity and retention. So those are the areas of evaluation that we carried out. So now it's time to look at a bit of what is the impact of our model been. So far in East and North Herts, we've trained 126 champions across the areas, which equates to 21 homes. Additionally, we have trained another 9 homes in the other side of the county, which is a different clinical commissioning group. And now I'm going to let Paul talk through some of our medi-analytics slides that I just previously mentioned around hospital admissions.
Okay, thank you, Michelle, for covering all of that. So I'm very conscious of time. If I just explain medi-analytics. So medi-analytics is a company that Herts County Council and the CCGs developed a relationship 2 years ago to pull varying data sets together into one source, pseudo-anonymized, so actually you can't track back the individual patient, but link the data sets. So instead of relying on postcode data, we are actually able to individually track the patients through the system and through various systems such as the acute system, the community system, mental health, whilst at the same time still being information governance compliance. So what we've also done is we've asked medi-analytics, the company, to statistically see if what we're doing has made a difference. So the slide that you've got up in front of you, the black line is all the care homes in East North Herts who haven't attended the training, and the blue line is the complex care premium wave 1, and we've split them out to see if they've made a difference. So as you can see, when the training started and then when the training finished, there has been a reduction, and we can statistically say, and this is an independent evaluator, say that following the training there has been a significant difference between the non-complex care homes and the other complex care homes. Okay, as I said, I'm conscious of time, so I'm just going to whiz through the rest of the slides that have been pulled together from the medi-analytics. Community contacts. So we can see the wave 1 residents show a higher rate of community contacts instead of the non-wave residents. So this is promising. As I say, it's early days, but this is promising that we're starting to use the wraparound services that we've developed. Moving on to the next slide. We've got the amount of days on average was spent in hospital. We can see statistically that following the training, wave 1 residents spent less time in hospital. Now I do have to caveat that with these are a small amount of homes. However, we have taken levelled all the care homes up by the hundreds. Moving on to the next slide is the mental health admissions. So you'll see it was flatlining in 2013. That's due to not having the data. That's the reason for the low level. However, we can see following the training, initial data has shown that that none of the Wave 1 residents were admitted to a mental health provider. So this is all looking initially positive, but we continually evaluate the model, and as Michelle was mentioning, we're working with the LSE to actually look at the evaluation. Okay, if we go on to the next slide.
So this slide was due to be a video that we've got of some champions and managers talking, but due to time, what I'll do is I'll send around the link. What the video does is it allows you to see the managers and the champions and what they feel the impact and what changes they've made because of the training. So just a few lessons we learned by doing this, how important the engagement is with everyone. So getting the homes engaged early and signed up and ready to do the project and why they can see the benefits of it, but also the engagement of people like the GPs and the district nurses, because where this project has really worked in homes is where the GPs and the district nurses are talking to those homes and talking to those champions and really working on those, trusting them and working for those residents. One of the keys is also how much the managers are supporting the champions. Where we've had homes where the managers haven't been as supportive, it has had a critical effect on the champions embedding their learning. We found that we needed to spread out the training more because otherwise it was too much for the homes in one go. We needed to make sure that we had ongoing support, so that's why we introduced the support visits where we go out and sit with the team, see how the champions are getting on. We needed to make sure that the levels of learning were right. We may be having people that were coming on this training that haven't been in a formal learning setting for 10 to 30 years. So we needed to make sure we pitched it all properly, and also the volume of the coursework that the champions had to complete. We made this so that they could do as much in the classroom as possible, because we understand how busy it is within the home and we don't want people to be doing assignments when they should be caring for someone. So they're just a few lessons that we have so far. One of that I mentioned earlier, it's not on the slide, but in terms of the payments, so we've moved from, we had the £70 per week where they would say if a certain local authority resident met a complex criteria. What we found is it was quite heavily burdensome for with lots and lots of applications for complexities and payments coming in from a contract perspective and a homes perspective. And what we didn't also feel, it didn't support the ethos of what this is all about. So going forward, where we're introducing to the homes from the 1st of November, we are, it's not going to be based on specific residents per week. We've analysed the data and found that on average, it's 25% of residents of local authority residents that meet complexities. So we've worked out a figure for the homes that they would get for that amount, and then they need to meet certain criteria. So they always have to have 4 of the 6 champions in place, for example. They need to be meeting certain admission figures. So we've set out new criteria so that they will be getting paid a bulk payment monthly rather than having to apply for individual residents. That's not in place yet, but I thought it was important to mention because it does feel like a better way of running the payments process. And what we're looking at now is what we call the building blocks if you wanted to start this project or if you wanted to do something around it. So one of the keys is you need a supportive management team. You need champions that are willing to get involved. You need integrated commissioning because, as Corbyn mentioned earlier, they do all their monitoring is all done together. So someone from the CCG side and someone from the local authority side do their commissioning together. Willingness of the clinical leads to get involved. Willingness of the locality to be involved and share data and how it's going. That a home has good financial stability. that the home has sufficient staffing and that the homes want to engage in the first place. If you don't have engagement with homes in your area, you'll need to work on that before taking the next steps. So to overview, we've looked at the problem, we looked at what our mandate was in our project team, we looked at how we engaged and how we developed the programme, how we analysed it, and then how we delivered and supported and evaluated. Now in the future, we've developed some slightly different models. We're doing what is called complex care access, which just focuses on champions around dementia, and the complex care foundation, which has the same champions as the complex care premium. However, the big difference is one of our lessons learned was that for homes that maybe aren't as high in monitoring scores and doing as well, that they may be going with the full advanced pathway champions is a bit too much at first. So we're doing programs that are slightly smaller that then they can top up to become the premium homes. And then what we're doing a lot of work on at the moment is CPD for the champions, making sure that they're kept up to date with their knowledge and that they're furthering their skills. Now, I'll go to the next slide because I'm sure there is some questions that people want answering. So I will hand over to Sue to do that. But we will be sending around this slide. We'll send around all the links. We'll send the links to the documentation, and people can drop me an email and ask me if there's any questions that don't come up. So if Sue has any questions?
Hi there. Because of time, I'm going to ask you one question, and to reiterate that all the questions that have come up, we will be doing an FAQ, and that will be sent out to everybody as well. So just because it hasn't been answered today, we will get things down on paper and send them out to you. So one key question is about staff turnover.
Yes.
How has this been an issue for training champions and then keeping champions once you've trained them, because turnover is an issue?
Yeah, well, it varies from home to home, to be honest. The initial analysis I've done on it, for the independent homes, retention has been high. Champions have stayed, they've felt appreciated, recognised, they've wanted to stay at that organisation. So turnover in those homes has been particularly low. Where we've had an issue with turnover of staff and champions leaving is actually the multi-owned homes, which we've got a few of on our project. So they're nationally owned homes. That's where we've had a higher turnover of champion. And when we've looked into the reasoning behind that, it's because where management hasn't allowed them to make the changes that they want to go to a home where they can really be a champion and put their changes into place. So that's something we're working at a national level with NHSE at the moment. What can we do to help the champions in these homes stay and feel appreciated? Because what we have seen is that where in the smaller independent homes, the champions do want to stay.
Lovely, thank you very much. Can you reiterate the website for people, or will this come out on a piece of paper as well? That we will email everybody afterwards. So will they get links to all of this? And someone's just asking about the CCA and the CCF as well. Will there be links for those, please?
Yes, there's links on our website with the details of those, and just on this last slide here, you've got the link to the Eastern North Park Vanguard website with our information. But we'll share any other links that we think are useful in the email that follows.
Thank you very much.
And yes, I've just read a question myself. The complex care access could be adopted in other areas as well as the premium. It's just it's a much smaller scale than the premium project, essentially.
Okay, so we're just going to wrap up there. So thanks for everyone.
I'll just ask a quick question because I think it's important. Someone's just mentioned about does the money filter down to the champions? And I think that's important because we haven't told homes where they have to spend that extra money. It goes back into other homes. But where I was just talking about the homes where champions have stayed, they also link that they are the homes where the champions have had their job roles changed. It's really been embedded in the roles and they've been either given an uplift or a bonus because of the extra work that they've been doing as a champion. So we do push that the champion should receive some kind of uplift for the extra work that they do.
Okay, so just to wrap up, thank you for everyone's time. As mentioned, we'll send out one email, and that will include a link to this presentation on SlideShare, a link to this presentation on YouTube, the FAQs and the documents that we mentioned, and also finally, just to request, there'll be a survey. If everyone could, we'd appreciate everyone's feedback. That helps us develop and do more webinars for next time. But just say thank you for your time.
Thank you.